core concepts of the particular topic which can be easily understood and applied in your day-to-day practice. So that is the sole purpose of my talks. Now, if I ask all of you, what you understand from the term called as a respiratory failure? In very simple, don't give me a textbook definition. Just tell me what do you understand from the respiratory failure. Akash, what is your understanding of respiratory failure?
Sir, according to me, when normal oxygen is actually not happening in the alveoli, it has to be a normal. That's the respiratory failure.
Yes, okay, good enough. Nisar, what is your idea about the respiratory failure?
I think, sir, when patient cannot maintain oxygen level in the blood and there is tissue hypoxia, that means respiratory failure.
Akshay, what is your perception about the respiratory failure?
Yeah, I think tissue hypoxia and then starting from lungs to blood to the last cell perfusion, I think everything can be.
Okay, so now I'm
Yeah,
coming to the point.
yeah.
Okay, fine. Let me understand you one thing very important. All of what you have given the definition to a certain extent that fits into the definition of a shock. A shock is a clinical state where inadequate oxygen delivery to the tissue to a organ happens, that is called as a shock. Shock does not mean that is a hypotension. Please understand the shock occurs much before it. So the impairment of the delivery of the oxygen to the cell, to a tissue, to an organ is called as a shock state. You're understanding this point? Basically, when I talk about the respiratory failure, it is the impairment of the gas exchange somewhere in the lungs. That is something what we call it as a. So it is either manifested as a deficiency of the oxygen in the blood, that is a hypoxia, or there is an accumulation of the carbon dioxide. Based upon this, they have simply classified as a type 1, where only there is a low oxygen tension with a normal carbon dioxide level, type 2 in which there is a low oxygen but elevated carbon dioxide. When you understand there is an elevated carbon dioxide through arterial blood gas analysis, it usually implies it is a hypoventilation. The lung is not able to throw excessive amount of the carbon dioxide which is produced. Now, the significance lies in one word. When you see a hypoxemia with a hypercapnia, you have to be very careful by giving more oxygen. In one word, if I want to tell you about the respiratory failure, the whole the hierarchy of the management lies that the system should receive adequate oxygen. Please understand this word, adequate oxygen. But in the case of type 2 respiratory failure, the moment when you try to load with a very high amount of oxygen, there can be a paradoxical worsening of the carbon dioxide, which we don't want. I'll come to that point later on. That is already given in the textbook. If you read any book, you'll get it. Now, before we go to understand the respiratory failure, please understand three important things. The shunt, ventilation perfusion mismatch, and third important cause is the central cause, that is in hypoventilation. Remember one very simple thing which I'm going to tell you about is shunt is a condition where the blood vessel bypasses the lung and the blood is not properly oxygenated. That is to say, when the alveoli or the part of the lung are perfused with the blood as normal, but the ventilation, that is the supply of air, fails to supply the perfused region of the lung. This results in returning of the deoxygenated blood from the right heart back to the left heart. I'll put it in a very simple way. Shunt has to be understood very well. Why I'm telling you. Suppose there is a pneumonia. The entire segment of the lung is consolidated. So the blood to that particular part of the consolidation is able to reach. What is not happening is the ventilation because the part is fully full with the exudate. The alveoli is filled with the inflammatory exudate, the pus, the macrophages, the neutrophils, the lymphocytes. So it is fully filled. So the ventilation is not happening, but the blood reaches the that particular segment of the lung, which is consolidated, and the deoxygenated blood from the right heart without going to that particular region returns back to the lung. So that is called as a shunt. Where in the case you have to understand the ventilation perfusion mismatch. What is the meaning of the word ventilation perfusion mismatch? Is when the part of a lung receives an oxygen without the blood flow, or a blood flow without an oxygen. So that is called as a ventilation perfusion mismatch. This is very, very, very important thing to understand. And third is the reason for the hypoxemia is the hypoventilation. Hypoventilation is a word when I try to use it is basically effect of certain the central reasons where the lung is not able to throw the oxygen out of the blood, uh, carbon dioxide out of the blood. So in that case, hypoventilation, the hypercapnia occurs, the level of the CO2 increases. Is that clear? Is that clear? So the first thing after going home, dear friends, then once you go home, the first thing what you should see here is you're going to study about the shunt, ventilation perfusion mismatch, and the hypoventilation. If you don't understand these three terms in a very clear way, you're not going to understand about the respiratory failure. Now you will tell me, sir, what difference it makes to me. मेरे को तो क्या करना है? It hardly matters. No, your entire treatment depends upon this particular definition of the term. So, an acute respiratory failure occurs when the dysfunction of the respiratory system results in abnormal gas exchange that is potentially life threatening. That you have to remember very, 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 very clearly. So, there are a lot of reasons like type 1 respiratory failure, type 2 respiratory failure, mixed respiratory failure, and the management is given all here. Now, when you're just trying to, I hope the concepts and idea about the shunt and ventilation perfusion mismatch is clear. Pulmonary embolism is a typical example of ventilation perfusion mismatch. Asthma, COPD, obstructive airway disease, ventilation perfusion mismatch. Pneumonia, shunt, basically shunt. Why? Now, I must tell you one thing very importantly. Why I'm trying to tell all these things is that it has a direct effect in the management. Now, what is the direct effect? Please understand the ventilation perfusion mismatch is distinguished from shunt. For example, your patient is hypoxic respiratory failure at getting admitted. The moment you try to give a small amount of oxygen, FiO2, even with a small additional amount of oxygen when you give to your patients who's admitted with a respiratory failure, in the case of ventilation perfusion mismatch, what happens is there is an increase in the FiO2. So there will be equally increase in the saturation level. That means, suppose if you're giving, I'm having breathless, and for example, you're giving me a bit of oxygen, say 2 liters of oxygen through nasal prong, and you don't know whether I have a ventilation perfusion mismatch or I have got a shunt. Even with 1 liter or 2 liters of oxygen, even my saturation, which was now 82, has come to more than 92, 93. So all critically ill patient, you have to maintain the saturation over and above 94. That is more than sufficient. In other words, the partial pressure of the oxygen in the blood is 60 or above than that. It is as good as you have achieved 90. So you don't have to be very aggressive. So small increase in the FiO2 creates a good amount of difference in the partial pressure of the oxygen when you measure through the oximetry. That is happening in the case of ventilation perfusion mismatch, asthma, COPD, pulmonary embolism. You have a huge difference, huge difference. Wherein in the case, even after giving 2 or 3 liters of oxygen, there is no significant improvement in my respiratory condition or in my saturation of the oxygen. That usually implies it is shunt defect. So there where the differences occur. Is that very clear, Akshay? So
Yeah, yes, sir.
yes. So you have to understand the very common cause of the respiratory failure is ARDS, pneumonia, lung collapse, cardiogenic pulmonary edema, pulmonary embolism, lung contusions, as in the case of injury. And the very commonest cause, which I'm going to tell you about, the primary hypercapnic respiratory failure, in which the carbon dioxide retentions are more, that is COPD, asthma, and certain drugs which impair the respiratory system. For example, GBS syndrome, myasthenia gravis, polymyositis, and certain hypothyroidism. So all these things, diaphragmatic paralysis, intercostal muscle weakness, and the neuromuscular respiratory failure. Now, all of three, please understand, in the case of hypoventilation, where the carbon dioxide is retained in the blood, and the patient is in the respiratory failure, please take home this message. The patient will not be in a respiratory distress. What are the features of respiratory failure? Tachypnea, breathlessness, air hungerness, diaphoresis, restlessness, agitation. All these features are seen. Beware that the most important pitfall in the case of a neuromuscular causes of the respiratory failure, the patient will not have any of this symptom. The patient will be having a typical myopathic face, expressionless face, and a patient who has got a muscle weakness with an expressionless face, be careful to see this patient is in the impending respiratory failure. The patient won't be in distress at all. And just if you miss this opportunity, you lose the patient. So the take-home message from the examination point of view as well as from the clinical point of view, all those patients whom you think, suppose in the case of diaphragmatic paralysis, you'll ask me, sir, how would you differentiate a diaphragmatic paralysis? A paradoxical abdominal breathing, typically implies that is a diaphragmatic. You can simply ask your radiologist, first just see the diaphragmatic movement. This patient is breathing in a very different way. It is an abdominothoracic type of breathing, very different type. I have not seen this. So the moment he puts a probe on the diaphragm, he can see the paradoxical movement or the diaphragmatic paralysis. A patient with a polymyositis comes to you with it. The respiratory rate can be hardly 6, 7, 8. One should be very careful. And I'll tell you, majority of the time, when the patient has got a tachypnea, it is visible. But when the patient has a bradypnea, it is not visible. It's very difficult, and often you miss this opportunity. Don't come to the patient is going to respiratory failure. So here in the case, you do a simple bedside FVC, forced vital capacity, and if the forced vital capacity is less than, I'm using the word less than the forced vital capacity is less than 15 ml, 15 ml per kilogram. That is an indication without fail you have to intubate the patient right away. Is that clear, Akshay? So then, so take home message: the neuromuscular cause of respiratory failure, the patient will not be in a distress. They'll have a typical myopathic phase. Check for the FVC. The patient won't be in tachypnea. Rather, check the FVC if it is less than 15 ml, or in simple, it is less than 1 liter. Don't waste your time. Immediately intubate it. So, okay, now, very important thing is there's one more type of method you can calculate the respiratory failure is by calculation of PaO2 difference. That is typically called as alveolar to the arterial oxygen gradient. It is causes a difference. It is carries a P into the bracket A minus A, the bracket close O2. Okay, so that difference is to be seen. We used to usually do this in the past, but nowadays we don't use this very clearly. In those cases, say for example, when there is a decrease in the inspiratory air, like high altitude, you will have this type of, the normal PaO2. Okay, high altitude. And secondly, there is an increase in the difference between the alveolar and the arterial oxygen gradient. Means what is simple? I'll tell you what is alveolar and the arterial. The amount of oxygen within the alveoli and the amount of oxygen in the arterial. That difference is called as a gradient. Suppose in this case, if there is a normal gradient, that means you have to understand that patient is either having a hypoventilation or a high altitude. But in the cases where you see there is an increase in alveolar to the arterial oxygen gradient, which is increased, then it is called as either shunt or the perfusion mismatch. Very common vascular disease, pulmonary thromboembolism, ARDS, cardiogenic pulmonary edema, and all those things. Okay, so this is one of the important things by which you have to understand. Why I'm taking this topic, friends, because you'll not find this in the other textbook like Harrison. This type of explanation is not given. They've simply given us type 1, type 2 failure, and mixed one. And then you start managing the patients. So one thing has to be very, very, very important clear. The idea of shunt, the idea of ventilation perfusion mismatch, the idea about the hypoventilation, and the calculation of the typical alveolar to the arterial oxygen gradient. These simple things will help you to understand. So now coming back to the first important thing, remember the pathophysiology behind the respiratory failure is beautifully given. Number one, so it can be described in a very 6 different way. Either there is a decreased oxygen going into the lung, number one. Number two, there is a hypoventilation. The lung is not able to throw excess amount of the carbon dioxide. There can be a ventilation perfusion mismatch. Number three, there could be a shunt. Number four, and number five, any barriers of the diffusion of the oxygen into the alveolar and capillary blood that can also lead to the typical respiratory failure. And the last but not the least is a decrease in the concentration of the oxygen in the mixed venous blood in the pulmonary artery. Mixed venous blood. Now, mixed venous blood, this you have to understand. Usually it is done by taking the blood from the pulmonary artery. Basically, we do the pulmonary artery Swan-Ganz catheter. We try to collect it and we see the mixed venous oxygen saturation. We'll come to that point in the later part. Okay. Now, is that clear difference between the shunt and the ventilation perfusion mismatch? Okay.
Yes, sir.
What's the difference? A small, suppose now you tell me, I'm giving a small amount of oxygen, but there is a good amount of saturation which is increasing. So what it could be?
Ventilation perfusion mismatch.
Ventilation
Yes.
perfusion, yeah.
But even after giving a very high amount of oxygen, I cannot see an appreciable difference in the saturation oxygen saturation, what it can be?
And
Shunt.
It can be.
Shunt, yeah.
And what about in the case there is an hypoxia, even there is a retention of carbon dioxide, it could be hypoventilation, type 2 respiratory failure. So what precautions will you take in the case of a type 2 respiratory failure? Start with the low oxygen, look at the carbon dioxide, look at the oxygen level. If it is tolerated without a substantial increase in the carbon dioxide level, gradually increase 1 more liter of the FiO2 and check in for the levels of carbon dioxide. Arterial blood gases has to be repeated after 30 minutes, usually, because that is the only way we can calculate the carbon dioxide level in the blood. And then supposing, despite hypoxemia, after increasing the oxygen level, if the patient becomes more hypercapnic, what would be a next plan of management? Despite oxygen,
And
you're
I,
trying to exactly. You have to think about the mechanical ventilation. So, very important message, a patient whom you have diagnosed as a type 2 respiratory failure is having an hypoxia. You're trying to escalate the dose of the oxygen by using Venturi mask or the Venturi principle. And after a short increment, there may not be an appreciable improvement in the hypoxemia. On contrary, there can be worsening of the hypercapnia. That is an indication before you delay. You have to start giving mechanical ventilation. The most important thing is NIV. Now, coming to the point
NIV,
is
yeah.
yes. So, and simple thing you should
Uh,
remember.
so, uh, yeah, yeah. Sorry, अंदर range कम आ रहा है, तो I may get disconnected
Fine.
in the
No worries.
hospital. So I'll see the recording film.
Yes.
Yeah.
So you should be well aware about the clinical manifestation of hypoxemia and hypercapnia. Hypoxia will have a tachycardia, tachypnea, anxiety, diaphoresis, altered mental status, confusion, cyanosis, hypotension, bradycardia, and seizures. Coma, even lactic acidosis, where in the case of hypercapnia, will have a typical somnolence, lethargy, restlessness, tremors, slurred speech, headache, and papilledema, coma. Remember one thing, when the patient is having excessive amount of the carbon dioxide, they are very agitated, very restless. Dear doctors, when you are on duty and managing these patients, the nurses at times are very much disturbed and perturbed with these type of patients because the patients are highly agitated. So without asking you, there are the cases on the medical records. The nurse used to give sedative drugs to these patients who are having a CO2 retention. It is as good as adding fuel to the fire. Do not administer any drug which is further going to lead to hypoventilation and retention of carbon dioxide, and that may culminate into the frank respiratory failure. Avoid giving sedatives. And if your patient is going in that carbon dioxide retention, as what rightly Akshay has said, immediately start NIV without wasting the further time. Is that clear? Okay, so the first thing what you're going to see in the management of the respiratory failure after you get an arterial blood gas is done, is there a hypoxemia? Number one, is there a hypercapnia? What can be the nature of respiratory failure? Shunt or ventilation perfusion mismatch, or it can be both, either extreme forms. Is there an hypoventilation? Is the patient has got some other disease which is the disorders of the central nervous system where which is causing a hypoventilation that you have to see, and you should be able to understand and interpret the arterial blood gases analysis. Now, what are the basic investigations you should do? There are the list of investigation you can do. The simple is a chest radiography. The chest radiograph can definitely help to understand many more pathologies. For example, in the cases, either you can have a normal X-ray chest with respiratory failure. Can you give me an example where the X-ray chest is normal and you have a respiratory failure?
pulmonary embolism.
It can be absolutely normal, tachypnic patient with an embolism, but in certain cases, you had a wedge-shaped infarct, which is seen, oligemic lung veins can be seen in
Yeah,
pulmonary
later on. Yeah.
embolism. Asthma,
Asthma.
COPD, exuded, they can have a very normal X-ray. There could be a localized alveolar filling. When you have a localized scattered alveolar filling opacities, it is usually resembling either a typical pneumonia or a viral pneumonia. When you have a frank consolidation lobar pneumonia, it can be bacterial pneumonia. When you have diffuse alveolar opacities, complete white lung field, you have to think about it. It could be ARDS as
ARDS.
well, because the management will definitely change. So an X-ray chest is the common and the basic investigation. And I think every doctor, the physician, especially who is dealing with the intensive care medicine, should be well aware. This lecture is not for the intensivist. This is for the physician who is on acute medicine call. So you should be able to understand a simple X-ray chest can definitely create a typical battering appearance on the X-ray that could be a pulmonary edema. So you should be able to differentiate it. The other investigations you should never forget is about a CT scan you can do, arterial blood gases you can do, and you have to see even the thyroid hormone levels, look for the presence of other comorbid risk condition which can precipitate. Whenever possible in the patients, if you can get a pure sputum, send it for the gram staining, send it for the culture. At times you can use the molecular methods nowadays, it's easily available. You cannot do the sensitivity, you can able to delineate the organism. So do all those investigations what is required in your patients, and that will help you to understand the exact reason. Remember now the management of the respiratory failure, which is a very important point which I want to come across, is understand the very core. The management of the entire respiratory failure is to maintain the normal oxygen level in the blood. That is the core. And how to manage this is very important. But very important, first is the priority is to keep the oxygen levels as to the normal level. For the practical purpose, keep SpO2 above 94. Sufficient enough. Even the partial pressure of the oxygen in the blood, if you try to keep it more than 60, they have found in the various trials that it is as good as having more than 90 mm of mercury of the oxygen in the arterial blood. So two important aspects. And the third important thing, remember, always try to understand what is the exact reason for the respiratory. Until and unless you do not understand, you cannot be able to exactly manage the respiratory failure. Take care of the etiology, the respiration will take care of itself. For example, a massive pulmonary embolism leading to the respiratory failure, no point immediately thrombolize the patient. Getting it? Cardiogenic pulmonary edema leading to the respiratory failure, give a high dose diuretic, trap the patient. If there is a large pneumonia leading to the shunt and respiratory failure, immediately start with the broad spectrum antibiotic and the patient is not. So I'll give you a very important idea, a stepwise fashion. Remember, a simple nasal prongs of oxygen is very effective in maintaining the saturation. If it is not, and you require more than 6 liters of nasal prong, go for a mask. If the patient is not able to bear the mask, use a non-rebreathing mask. And if not, you can use a high-flow nasal cannulas, which are refillable, in which you can give a very high amount of oxygen, 60%, 80% of the oxygen. And by using this, you can prevent the patient from going onto a mechanical ventilator. Meanwhile, on the other hand, take a good history, perform a good respiratory examination, try to delineate what can be the reason for the respiratory failure. So this is very important. So that is what it has been clearly said about the management of the acute respiratory failure depends upon the cause, the clinical manifestation, the patient's underlying condition. Certain goals apply to all patients. Improvement of the hypoxemia to eliminate or markedly reduce the acute threat of life. Improvement of the acidosis if it is considered life-threatening, and maintenance of the cardiac output is very important. Now, when you see the patient who's in respiratory failure, often they're into the acidosis. Don't bother about it, the acidosis part. Just try to treat the underlying etiology. Only when the acidosis is less than 7.15 or the acidosis is causing severe life-threatening arrhythmia, then and only then think about giving soda bicarb. Otherwise, no, try to avoid it. Second important thing, the patients with the respiratory failure often have impaired cardiac output. On top of it, when you try to put them on ventilator, say positive pressure ventilator or intubation, the cardiac output may further fall down. So under all conditions, by using vasopressors, you have to maintain the adequate cardiac output. But there is a caveat and pitfall. While managing a case of the ARDS, do not judiciously give IV fluid. It can be deleterious. On contrary, if there is a case of an ARDS, keep the patient prone and try to restrict the fluid. Try to restrict the fluid. Do not give liberal fluid. On the other hand, in elderly men with a pneumonia getting admitted, the judicious use of IV fluid is required because the patient is often dehydrated. And after hydrating such patients, the sputum production is good, the respiratory secretions are getting better. But on the contrary of the ARDS, you have to restrict the fluid intake. So it is you who has to take a call which patient should be given a judicious IV fluid, which patient should not be given judicious IV fluid. So the cardiac output, acidosis, all this thing has to be taken. But remember, in the due course of the management of the respiratory failure, these are very temporary, the hindrances, which will resolve over a period of time. Focus on the etiology, focus on maintaining the oxygen level. If not on prongs, on mask. If not on mask, high flow nasal cannula. If not on that, then non-invasive ventilator. If not on that, then think about the mechanical ventilator part. That will come the last. But you can prevent the patient from going into it. Okay? Clear? Is that clear
Yes,
up
sir.
till now?
Yes, sir.
So the maintenance
Yes,
of the
sir.
cardiac output is very crucial for the oxygen delivery. Remember one thing, avoid giving transfusion in case if the hemoglobin is over and above 10 gram. It can be deleterious. If the hemoglobin is less than 8, number one, in presence of heart failure, angina, or cerebral ischemia, that is an indication where you can think about giving a blood transfusion. Otherwise, try avoid giving blood transfusion to these group of patients. There are the data, but by giving a PRBC, red blood cell transfusion, has led to the worsening of the sepsis because it reduces the immunity. It predisposes the patient for the more bacterial pneumonia. So you have to be very careful. And in case where the hemoglobin is more than 10, do not think of attempting or giving more packed cell transfusion. Remember, when the patients are having a low blood pressure or the mean arterial pressure is less than 65, temporarily you need to give certain vasopressors. The most common vasopressor we use nowadays is noradrenaline infusions. Okay, so once the overall underlying condition improves, spontaneous improvement in the oxygen levels are been noted. Now, as I said you, the first important thing is a therapy to improve the oxygen. Now you tell me, how will you improve? Initial step is start with the low flow nasal oxygen, let's say 2 liters a minute. If there is no appropriate improvement in the saturation, advance to 6 liters a minute. And if still the hypoxemia persists, then you start a high flow nasal oxygen. It is available as a device in certain ICUs, like 15 or 20 liters, then you can escalate to 60 liters. Try to keep it between 50 to 100% also, but we try avoid giving it and try to maintain the saturation more than 94%. You don't have to bring it 100%. Remember, 100% oxygen is required in certain type of respiratory failure as to begin with. But the moment you attain the saturation, try to reduce your oxygen from 100% to 70%, because there are no clear, but an arbitrarily it is believed that an oxygen more than 70% is injurious to health. It creates an oxidative damage to the system. So you can start with 100%. The moment you can see the saturation is over and above 94%, try to reduce it to 70. So more than 70% of the oxygen has been believed to be injurious or deleterious. Okay. So a PaO2, please take home this message, underline this point. A PaO2 greater than 60 mm of mercury is usually adequate to produce an SaO2 in the low to middle of 90s and provide an adequate oxygen content of the blood for tissue oxygenation. This is a take home message. So you don't have to get your partial pressure of the oxygen in the blood to more than 90-95% in the initial stage. No, even if you're trying to achieve around 60 through arterial blood gas, it is sufficient to maintain the saturation over and above 90, and it is good amount. The purpose of giving oxygen is it should reach to the tissue, it should reach to the organ. That is where it is very important thing you have to remember all these things. Now there are different types of nasal and the face mask for the oxygen. The standard nasal prong can deliver FiO2 around 0.50%, and non-rebreathing mask can deliver up to 50 to 100%. Now it all depends upon the respiratory pattern and the flow rate. If only hypoventilation or ventilation perfusion mismatch is present, a small, as I said, a small increment in the FiO2 will make a good difference. But in the case of shunt, so is not as the picture. Is that clear?
Yes.
Yes, sir.
Yes. So you have to remember this thing very clearly. And there are different ways by which you can give. If your patient has got a COPD with a respiratory failure, do not try to suddenly go for 10 liters of oxygen, because it's a typical case of ventilation perfusion mismatch. Many other times, these patients have got an hypoxic respiratory drive. So try, but yes, remember one thing, that if the patient is hypoxic, even in the case of COPD, you're not going to deprive them of the oxygen. No. Start at 1 liter, 2 liter. And the best way to administer oxygen to the COPD patient, I would request everyone in your clinic, in your hospital, to keep at least venturi mask, 24, 28%, 35%, and that way. So different colors and balls are there. You have to use it. Works on the Venturi principle and precise O2. And the moment your SpO2 is more than 94 or more than around 92% in COPD patient, is more than sufficient enough. Should there be paradoxical rising or worsening of the carbon dioxide level in the blood, immediately go for
NIV.
NIV, non-invasive. You should not wait for it. Okay. So there are various high flow nasal oxygen. You can use it. And the benefit of the high flow nasal oxygen is what? You can reduce the subsequent rate of intubation in compared with the conventional oxygen delivery via face mask. Okay, and an FiO2 of more than 70% or higher is generally considered potentially harmful to the normal lung.
Patient.
Is this clear
Yes, sir.
to you?
Yes, sir.
So, in the nutshell, let's wind it up about the respiratory failure. Type 1, oxygen has to be given. Try to assess whether it is ventilation perfusion mismatch. Always try to assess the etiology. In type 2 respiratory failure, what are the basic principles? Start with the low oxygen. Try to avoid severe hypoxemia. Try to attain the SpO2 over and above 92% or near 94%, but not at an expense of rising carbon dioxide level. If it is so, try to reduce the oxygen 1 by 1 liter. See if the carbon dioxide is within range. If the carbon dioxide levels are rising further, and you can have a clinical feature of CO2 narcosis, without undue delay, start with
NIV.
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 Start with NIV. So, and in the case of the patient with the respiratory failure due to the neuromuscular cause, what is the most important message which I gave you today?
Mechanical ventilation.
Yes, they are in hyperventilation. They may not appear in
FVC.
distress. They
Forced
may not
vital
appear in
capacity.
distress. Exactly. Less than 15 ml per kilogram
Less
is one
than
of the
1 liter.
indications where exactly to put them on this thing. So the basic investigation is EBG, chest X-ray, ECG, complete blood test, sputum examination, and the bedside FEV1 and FVC ratio. You can do it if you suspect the patient has got. And always remember the patient with the respiratory failure. Always do a septic screening, which is very, very, very important point. I think you should not miss this point in the management. And when you see an X-ray, one more important thing I forgot to mention about is always when you see an X-ray, look for the Curly's line. There's a horizontal line seen in the peripheral of the lung field reaching up to the pleura. Very fine lines. The
Cardiogenic
presence of
pulmonary
careless
edema.
B line is interlobular. That's usually indicating of cardiogenic pulmonary edema. What is the significance of this? Now, there's one trial which has said that at the time of discharge, when you take an X-ray and if you're still able to find the careless B line, that means the patient is again going to get soon admitted to your hospital.
Okay.
So the presence of careless B line in a patient with a heart failure at the time of discharge indicates it is not properly managed. Is that clear?
Yes, sir.
Yeah, so that is one of the indications. And you should always see the red flags in the case of respiratory failure, inability to speak, an RR more than 40, the peak expiratory flow less than 33% of the predicted, tachycardia heart rate more than 100, or the bradycardia less than 60, severe exhaustion, coma. All these things portend a poor prognosis without undue delay. Meanwhile, you can start with an oxygen call for the senior, call the intensivist, arrange for the ventilator. The patient may require intubation. But nevertheless, do not deprive your patient from the oxygen. Even high flow oxygen can be maintained to a level you can maintain saturation over and above 94. That is what I've said you. If possible, more than 92% and 94% better. But don't try to achieve. If you're getting 100%, well and good. But I'm trying to tell you, but try to understand from the history whether the patient has got type 1 or whether the patient has got a COPD or not. This has to be seen, importantly. Also, one thing is that hypercapnia is an end result of many diseases, which ultimately ends up not just COPD, but many patients. A patient who has got a type 1, but now patient has been tired, fatigue. A tiring patient can also have hypercapnia. So it's an impending doom. So you should never forget all these things. So, and last, but what I've not I forgot to mention is whenever the patient comes, I often tell you in the clinical examination, carefully look at the patient's breathing pattern. You never forget to miss a strider.
Hmm.
Typical inspiratory noise, upper airway obstruction, stridor. It's a very common cause that you should always assess in a patient. So stridors, upper airway, the stridors has to be seen. If you find a stridor, immediately summon an ENT surgeon and make the patient sit upright. In the case of ARDS, till the time the advanced support come, ask the patient to be on prone position because the posterior segments of the lungs are poorly aerated. When you try to put it prone position, that particular segment gets more area for the oxygenation. So prone ventilation is very important as much as patient is comfortable. Even we are doing prone intubation and we have managed so many patients. Okay. And always try to ascertain the history because at times the hyperventilation because the patient may have taken alcohol or certain sedative drugs and all those things. So try to ascertain the history from the background, what can be the reason about these patients. Okay. So
Yes.
patient from your care, you can prevent the patient from going into the bad intensive care, from a critical acute medicine take to the intensive care. But there is a progressive exhaustion, loss of consciousness or impaired consciousness. There is a further drop in the mean arterial blood pressure less than 65 mm of mercury, progressive respiratory failure. Then better it is to shift the patient to the intensive care. So what are the key points? Do an early ABG analysis. It is important to distinguish from type 1 to type 2. Meanwhile, try to ascertain the very good history. Without addressing the underlying cause, you cannot manage the respiratory failure. Take care of the cause, maintain the oxygen, the entire rest of the thing, the body will take care of itself. You have to have a support treatment in between. Okay? So that is very important thing. At least NIV is very simple. You can manage with them. And always look for the neurological condition, cardiac condition, drug overdoses and all in the management of the respiratory failure. So in the next topic, now the respiratory failure is quite clear. In one line,
Yes, sir.
oxygenation is very important. In next chapter, I'll just teach you about managing a respiratory failure in COPD, managing a respiratory failure in ARDS. There are certain ventilatory protocols out there, which I'll be telling you in detail about it. After going home, I request all of you, you are going to open your book. It is not available. Knowledge is never gained from one single source. Try to understand the basic pathophysiology. Try to go back and read shunt, ventilation perfusion mismatch, the difference between the alveolar and arterial gradient. What is the significance? How can you imply? Analysis and interpretation of ABG and basics of the airways. Okay?
Yes.
Any question?
No, sir.
No, sir.
So next we'll see, and I'll just see, this is not for the intensive care, but I'll teach you the basics of the ventilators, like ACDC mode, SIMV mode, and about the peak plateau pressures, and the tidal volume, the respiratory rate, I and E ratios, and on ventilators and all. So you should be at least aware with these terminologies when the patient is on ventilator, because every patient is unique. The method of delivery is unique. Even I'll just give you a brief idea when to wean off from the mechanical ventilators. Like for example, daily try to reduce the sedative dose, neuromuscular blockade dose in the early morning hours by 7 a.m. and between 7 to 9 a.m. in the morning. See the patient is having a spontaneous breathing trial, whether the underlying disease which was reason responsible for this patient on venti is gone or not. The care of a patient who is mechanically ventilated. Always remember the patient should be kept propped up. Subglottic suctioning has to be done. Frequent chlorhexidine mouth clean has to be done because of ventilator-associated pneumonia is worse. So the frequent cleaning of the mouth with the chlorhexidine is required. Scheduled circuit change once in 7 days or 8 days or 10 days like that. So small things which I'll be telling the patient is on ventilator. A physician looking after a patient who is on venti. Definitely, because in the ICU, the intensivist will be available to look after it. Is not your consultant. But you should be well aware with what are those terminologies pertaining to the ventilators, what are the settings, pertaining to the ARDS. Supposing, for example, the patient's pH is dropping and the peak pressure is going more than 35 mm of mercury, then in that case, you have to reduce by 1 ml of the tidal volume. So those things, prone ventilation, fluid restrictions, broad spectrum antibiotic, all those things that we'll discuss in the next subsequent lecture. I think by the time you should have some idea about it. Okay?
Okay,
Any
sir.
question?
No, sir.
No, sir.
You can stop the recording, Akshay.
Okay, sir.
Nisarg.